Good morning, everyone. Thanks for bearing with us and joining us today. My name is Louis DeSanto. I'm a Regional Resource Director at Caron Treatment Centers, and I want to thank you again for joining the webinar on today's topic, Brain Breakthroughs, Transforming Substance Use and Behavioral Health Treatment. As a reminder, we'll be conducting the session as a webinar, meaning all participants are muted and videos are turned off. During the presentation, we'll turn off the chat, but you can utilize the Q&A feature to ask any questions. If we're unable to get to your question before the end of the hour, we'll have someone from our team follow up with you directly. They will also follow up with the presentation slides and a recording of the webinar via email once it's available. Today's presentation is eligible for 1 continuing education credit. We would like to thank our educational partner, CE Learning Systems, for assisting in providing these credits through co-sponsorship with the American Psychological Association. Please note that in order to receive your credits, you will need to be on for the entirety of the program and complete the post-webinar evaluation. So watch out for a link that will be emailed to you directly after the presentation. And after you finish the evaluation, you'll have immediate access to your certificate of completion. As helping professionals, we understand that the profound impacts that substance use disorder and other mental health conditions can have on our patients physically, mentally, and spiritually. Getting to the root of the problem and forging a path to recovery begins with optimizing brain function. And today, we welcome 2 experts who will discuss how assessing, diagnosing, and treating the brain is an essential tool to help our patients achieve greater outcomes. First, I'd like to introduce Dr. Amber Deckard, who is the Director of Neuropsychological and Psychological Services at Caron Treatment Centers. With over a decade of experience in neuropsychology, Dr. Deckard leads a team dedicated to advancing psychological and neuropsychological evaluations, specializing in the assessment of cognitive and behavioral impacts of injuries, illnesses, and psychological disorders. Joining Dr. Deckard is Tracey, the Director of Neurocognitive Services at Caron. With 6 years of working in behavioral healthcare, Ciaran specializes in implementing and maintaining neurotherapy programs, particularly in treating substance use and mental health. So thank you, Dr. Deckard and Ciaran, for joining us today.
Thank you for introducing us. Good morning, everyone. Today, we will aim to briefly boost the understanding of neurorestorative health care in a substance use disorder setting. We'll review the core components of a neurorestorative model, explore the key brain areas vulnerable to substance use, discuss the role of modern technology in diagnostics and treatment, and emphasize the importance of measuring therapeutic outcomes to ensure effective, evidence-based care. And then lastly, we'll focus on the importance of measuring therapeutic outcomes and briefly review some findings. As a field, we recognize the necessity of addressing psychosocial factors to successfully treat addiction. If we had time, a proper review of treatment history would show substantial progress from punitive measures to evidence-based therapies. However, the current persistently high relapse rates of 40 to 60% overall, and 70% for alcohol use disorder highlight a glaring gap. While we treat symptoms effectively, we are not achieving sustained recovery for many individuals. This gap calls for a transformative leap in our treatment paradigm. That call is being answered with a neurorestorative healthcare model. By enhancing and integrating our current treatment modalities with neuroscience, we are not just aiming for abstinence, we are facilitating a deeper and more durable recovery. And by enhancing brain function and addressing the neurological impacts of addiction, we aim to significantly improve the odds of sustaining abstinence. So what is neurorestorative healthcare? Neurorestorative healthcare is not just a treatment. It is a truly transformational care model that focuses on directly targeting the brain to heal the underlying neurological impacts of addiction, enhancing brain function and functions to improve overall health and wellness, rebuilding and forming new neural connections that are essential for recovery, combining various modalities to provide a unified approach to treatment, using the latest findings in neuroscience to inform and guide treatment strategies. And then lastly, ensuring sustainable healing that supports a lifetime of recovery and well-being. Ultimately, briefly, in looking at the neurorestorative healthcare model here, you can see that each of us already play a role in the neurorestorative model in some way or another. For example, there are numerous bodily functions that are negatively impacted through substance use. Let's briefly look at 2 or 3, starting with the cardiovascular system. Stimulants such as cocaine and amphetamines drastically increase the risk of heart disease, hypertension, and arrhythmias, as these substances stimulate the heart and constrict blood vessels, placing users at an increased risk for cardiac events. Let's touch on nervous system and endocrine system. The nervous system is often impacted with the use of alcohol, stimulants, and inhalants, which can lead to neuropathy, seizures, and even strokes. While the endocrine system, which regulates hormones, can be disrupted by almost all substances, with opioids and anabolic steroids causing particularly profound imbalances here. Multiple areas are listed here on this slide. Without reading down every single system, this highlights the capacity that medical professionals are serving in and how you can continue to serve as a part of the neurorestorative model by focusing on the assessment, stabilization, diagnosis, and treatment of patients. This may include managing withdrawal symptoms through medically supervised detox, treating co-occurring physical health issues, monitoring overall physical well-being, overseeing neuroimaging, such as MRI, fMRI, or FDG PET scans, and also overseeing medical treatment, such as hyperbaric oxygen therapy. Two other crucial components of the neurorestorative healthcare model are psychiatry and individual therapy. These professions are vital for assessing and treating co-occurring mental health disorders, as they are closely linked to cognitive impairments, since the same disrupted neural pathways that affect our thinking and reasoning also play significant roles in regulating our emotions and behaviors. Understanding this connection helps us see how the brain's alteration by substances can lead not only to cognitive decline, but also to profound shifts in mood and personality, influencing the entire emotional landscape of those affected. In substance use settings, psychiatry often oversees the ongoing pharmaceutical treatment of the co-occurring mental health disorders, while the therapist often serves to help uncover and address underlying issues, teaching coping and problem-solving skills to manage cravings, avoiding triggers, to provide support and motivation. And given the complex histories endorsed within this demographic, it's imperative that they are provided trauma-informed and evidence-based therapies with offerings from multiple modalities, such as motivational interviewing, CBT, DBT, EMDR, and ACT. The neurological, physical, and psychological alterations caused by substance use not only challenge the individual, but also reverberate through their personal and professional relationships. This is where family and couples therapists come into the neurorestorative model. By evaluating the impact of family dynamics, involving family members in the recovery process, and addressing relational issues that may contribute to substance use, they can treat the patient and family system and provide ongoing support that has potential to increase resilience. Substance use often leads to a deep connection or disconnection, apologies, from spirituality. It distances patients from themselves and others, while sometimes severing their connection to God or a higher power. This disconnection can result in a profound sense of loss, purposelessness, which leads to eroding their moral and ethical values and can leave them feeling lost and devoid of meaning. Equally significant is the impact on physical fitness. Substance use often depletes energy levels, leading to constant fatigue, lack of motivation. It can affect coordination, causing trouble with balance and slower movement, which then increases the risk of injuries. Addressing these issues in a substance treatment setting requires a holistic approach, which is why spiritual and physical fitness are core components of the neurorestorative model. A spiritual coach can guide individuals in reconnecting with their spiritual selves. They can help restore a sense of purpose and meaning, rebuild moral and ethical values, and foster a connection to a higher power. This spiritual renewal can be a powerful motivator for recovery and personal growth. Notably, this can also be addressed in individual and family therapy from an existential treatment modality. Likewise, a fitness coach can play a crucial role in restoring their physical health by designing personalized fitness programs to increase energy levels, improve coordination, and rebuild strength. This, again, can reduce the risk of injury and also enhance their overall well-being. This brings us to the three remaining components that are vital to the neuro factor of the model. And these components, neuropsychology, neuroimaging, and neurotherapy, provide the in-depth assessment, objective findings, quantifiable outcome data, and repeatable measures that are essential to the model being evidence-based. Later in the presentation, we will briefly discuss neuropsychology and its role in substance use treatment. We will not have the time to discuss the multitude of assessments that can be used in a neuropsychological battery, but we'll look at outcomes after using the repeatable battery for the assessment of neuropsychological status, or in short, the RBANS, and the Milan Clinical Multi-Axial Inventory, or in short, MCMI. We also recognize that there are a multitude of neuroimaging techniques that are not listed here. However, later in the presentation, we will focus on primarily EEG and QEEG, as that provides a strong in-house and non-invasive baseline assessment prior to referral for more neuroimaging, such as the FDG PET or fMRI, if needed. We will also briefly discuss and introduce to you some neurotherapy techniques. In our field, the visible signs of the disorder are like the withering leaves and brittle branches of a diseased tree. They are the symptoms that catch our attention and often prompt an initial response. The more complex or severe symptoms may even progress or appear in the trunk of the tree. By comparing the extensive reach of the leaves in this image to the hidden vastness of the roots, we illustrate a key point. While the leaves, the visible impacts, are numerous and wide-reaching, the roots, or the neurological underpinnings, are more extensive. And so if we only treat what we see, we cannot achieve lasting recovery. So from here, we're going to move on to speak a little bit more about those key components in the brain.
Thank you for joining us. So let's have a look at the neurobiology of addiction and substance use. So we're going to look at this from two different positions. First, we're going to look at the neurobiological basis of addiction, particularly the regions involved during the addiction cycle, which are explained through the dopaminergic pathways, or simply the activation of dopamine during active periods of drug use. So these regions include the VTA, or the ventral tegmental area, which serves as the basis for dopamine projections and pathways. We also have the nucleus accumbens, which has a direct role in processing reward and pleasure, and the prefrontal cortex, particularly a deeper structure within the prefrontal cortex called the anterior cingulate gyrus, which will be highlighted extensively from this point forward, and how it governs our attention and our decision-making processes in the addiction reward cycle. It's such an emergent region of the brain, like I said, that plays a significant role in the manifestation of substance use disorder, as well as mental health disorders such as depression and PTSD. And so to facilitate this learning, we're going to show a quick and helpful video that neatly integrates these three regions via the dopaminergic pathways. And afterwards, I'll circle back to Dr. Deckard, where we will look at the brain via the important structures that are impacted through prolonged substance use. So if we can play the video.
In neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the reward system. The reward system refers to a group of structures that are activated whenever we experience something rewarding, like using an addictive drug.
Can you get stuck?
An area of the brainstem called the ventral tegmental area, or VTA. The VTA is one of the principal dopamine-producing areas in the brain, and the mesolimbic dopamine pathway connects it with the nucleus accumbens, a nucleus found in a part of the brain that is strongly associated with motivation and reward, called the ventral striatum. When we use an addictive drug or experience something rewarding, dopamine neurons in the VTA are activated. These neurons project to the nucleus accumbens via the mesolimbic dopamine pathway, and their activation causes dopamine levels in the nucleus accumbens to rise. Another major dopamine pathway, the mesocortical pathway, also originates in the VTA but travels to the cerebral cortex, specifically to the frontal lobes. It is also activated during rewarding experiences and is considered part of the reward system. Because dopamine is released whenever we use an addictive drug, researchers initially thought dopamine must be the neurotransmitter that causes pleasure. More recent research, however, suggests that dopamine activity doesn't correlate exactly with pleasure. For example, dopamine neurons are activated before a reward is actually received, and thus before the pleasure is experienced. For this and other reasons, it is now thought that dopamine has roles other than causing pleasure, such as assigning importance to environmental stimuli associated with rewards and increasing reward seeking. Whatever the precise role of dopamine in reward is, the mesolimbic dopamine pathway is consistently activated during rewarding experiences, leading it to be considered the main structure of the reward system. Regardless, the actual network of brain structures involved in mediating reward is much larger and more complex than just this dopamine pathway, involving many other brain regions and neurotransmitters.
So the key point... So the key point I really want us to take away from that is how the brain and these regions process dopamine or feelings of reward and pleasure, even without the direct activation of the drug. And so this is called incentive salience. And the anterior cingulate gyrus, so the prefrontal cortex, is a key player that's involved in this process. Incentive salience refers to how the brain can associate feelings of reward and pleasure with stimuli or cues that remind us or the individual of pleasurable experiences or using the drug. So things like places, sounds, smells, or even specific environments. So when exposed to these stimuli, the addicted or the dopamine sensitive brain has a really hard time of organizing our attention, salience, and action. Okay, so this is due to the addictive process during these moments. And this really, helps provide some insight and explain why relapse rates can be so high. Essentially, even when we are not using the drug, our brain is still processing feelings of reward and pleasure by previous association. So I'll hand it over to Dr. Deckard, where she will explain some of these regions and talk about the impacts that prolonged substance use has on these key areas.
Thank you. So first, let's briefly look at the key areas a little more. We won't go over every single area listed here, but the key areas being the VTA, or the ventral tegmental area, which plays a crucial role in the brain's reward system, as Ciaran stated. Substances like stimulants, opioids, and alcohol trigger the VTA to release dopamine, a neurotransmitter associated with pleasure and reward. This release reinforces the behavior of drug use, making the substance seem more appealing. Next, the nucleus accumbens, often referred to as the brain's pleasure center, is affected by virtually all abused substances. It's important because it's linked to the feelings of euphoria that many drugs provide, and is linked to why, and it can explain why drugs can be so addictive. Next, the prefrontal cortex, responsible for decision-making and impulse control, is significantly impaired by substances such as alcohol, stimulants, and cannabis. This impairment can lead to poor judgments and impulsive decisions, which then, as many of us know, that then further complicates the path to recovery. And then lastly, one of the key areas is the hippocampus, essential for memory formation. This is adversely affected by many substances, especially alcohol, which can lead to difficulties in learning new information. So you can imagine in this area, as far as the hippocampus goes, when you have somebody in treatment and they're participating in group and in individual therapy, and they're being exposed to stimuli where they're expected to learn auditorily or visually, apply it, and then use that as coping mechanisms or problem-solving skills. But if there is a barrier to learning new information and coding it, recalling it, this is where the importance of this part of the brain and why treating the brain first is so important, so that we can allow them to progress further and learn and apply the skills appropriately, so it increases their chances of sustained recovery.
All right, so let's look at neuroimaging, and as Dr. Deckard discussed, we're primarily going to focus on QEEG assessment, which is my main area of specialty. So, but before we discuss QEEG, it's important to establish the basis of it, which is EEG, okay? And so a lot of us are familiar most likely with EEG, and EEG is essentially a long-standing neuroimaging test that examines the brain's electrical activity. So we can see at the top that the translation actually directly refers to electrical brain picture, and that's essentially what we're trying to grab. So very similar to EKG, right, where we look at the electrical activity of the heart. K stands for cardiac, E in EEG stands for brain, it's Latin for brain. So EEG is a routine test that is prescribed to assess the electrical firing of the brain and provide a basis for any potential abnormalities, such as the conditions below: epilepsy, seizure disorders, brain injury, stroke, tumor lesions, and sleep disorders. So on the basis of a positive test, a diagnosis can be made, or further testing or evaluation can be recommended. So as we look at QEEG, we go to the next slide. So what is QEEG? QEEG is essentially quantitative EEG. So it's a statistical computation of electrical activity. And that's fancy term for meaning that we are basically comparing brain activity to what is considered normal. So QEEG was first established, back in the early 60s and 70s. When we first had the use of a digital computer, we were able to analyze EEG and map it from an electrical standpoint, which is the basis of what we become to know as a brain map. So when you hear the term brain map, it is a synonymous term for QEEG. So over time, with advancements in technology and thanks to calculation power of computers, we're able to create normative databases. So which, an individual's EEG activity can be compared to a healthy population of their peer group. So QEEG has become a very popular and advantageous assessment tool, mainly due to the emergence of neurotherapy, which we'll discuss later on. And a lot of people have ventured towards neurotherapy as a more naturalistic or less invasive way of treating clinical ailments, okay? So when we look at QEEG, we examine it through three main variables: where in the brain, so the location, so where are we seeing any dysregulation; frequency, so is the electrical activity slow or fast; and time, how much electrical energy is being produced over a recording or time period. And this is where we get our significance. All right, next slide. So why QEEG? So first and foremost, QEEG is objective. It gives us applicable data that can provide significant insight and validation for the patient's condition. So there's correlation with how we feel and what the data shows. It's measurable, so we can see to what degree or extent in terms of significance problem areas are dysregulated. And we can also measure on a continuum of time to evaluate progress. QEEG is also reliable and valid, right? So it has strict measures that assess reliability and validity to make sure data is accurate and consistent. It's non-invasive, user-friendly, so it's not intimidating setup for patients, very easy to use. And it's economical. So, and this is on both patient and clinician side. For a clinician, it's affordable to bring into a practice, and it's affordable for patients compared to other comprehensive neuroimaging assessments. So if we look at the next slide, so what is the goal of QEEG? And ultimately, the goal of QEEG is to provide symptomatic correlation to brain function. So how is the brain or nervous system holding us back emotionally, cognitively, and physically? We do this via 3 different forms of observation or analyses. So the conventional EEG, which is very important, and I would like to emphasize the importance of having a clinician who can do this well as read the QEEG. Conventional EEG observations involve looking at the EEG tracings before they are statistically compared to a normative database, so before looking at the brain map. But it goes a little bit past today's webinar, so we're going to have a basic overview of viewing the data from the more classic data points, which is the topographical maps, such as the brain maps, and source localization model, which I'll discuss here in a little bit more detail in a second. Okay, so before we have a look at some data, I just want to introduce you into some brain electrical frequencies 101. So what we are looking at here on the left is what a technician would see on the screen during a recording, which is the conventional EEG signals being recorded across 19 different regions of the brain. These EEG signals are made up of multitude of different electrical frequencies. So it's important to establish the individual power of these electrical frequencies across the brain. Having too much or too little power in a given frequency range is the basis of symptomatic presentation and functionality. So brain waves measure from slow to fast, okay? Kind of like gears in a car. So our slowest, if you look at the middle image, is our delta frequency range. And this is typically involved in clinical presentations that are restoration in nature, right? So we produce delta in deep sleep, in healing processes, in developmental processes. Our next slow wave activity is considered theta. So typically presented in hypoarousal states, so meditative states, imaginative states, deep relaxation. Our cruising speed, our middle guy is alpha, typically involved in inhibited states. So we see this in active rest, idle, disengagement, and our faster frequency states are beta, high beta, right? So typically involved in arousal and hyperarousal, so higher cognitive thinking, executive function, task performance, and high beta with the stress response. So fight or flight, which we more commonly know it as. All right, so let's have a quick look at normal distribution, just to provide some context of how we view the data before we look at some profiles. Identifying normal versus significant in the brain maps and other tests is based off the bell curve, right? It's something that Dr. Deckard will introduce also when we look at neuropsychological testing. We view anything as significant as plus or minus 2 standard deviations. Positive scores and standard deviation will be reflected in brighter colors such as orange and red. Negative scores in standard deviation will be reflected by darker blues. Scores less than 2 standard deviations on either side is what we would consider not significant, right? So within normal limits, and they're represented by more cooler colors of each end of the scale, with 0 or close to 0 being most optimal. All right. So when we look at the basic analysis of QEEG, this is a broad overview of what we would see. So on the left-hand side, we have our topographical surface brain maps organized in each of the frequency ranges. And so how you look at this, those little pink nodules to each side, you have the nose, left ear, right ear. So we're looking at the brain across these individual frequency ranges. And on the right is the source localization model, that highlights deeper regions of the brain. So this is what I wanted to introduce you to previously. And there's correlation between these two sets of data. Essentially, without overcomplicating it, what we see on the left in the topographical brain maps, hopefully we see the root cause on the right. Like Dr. Deckard introduced earlier, except in a more format exclusive to the brain, think about this system of interaction between flowers of the plant and the root system of that plant. Okay, so ultimately this level of information we have is very important because it gives us greater insight of what specific deeper structures in the brain are the root cause of the widespread cortical electrical activity that we see in the brain maps. And so if you're wondering, well, what is the problem with this person? You would be still validated in that search process. This is considered healthy, right? So if we see our color schema below, the cooler colors such as white and green represent normal or non-significant activity. So this is actually a well-functional brain from the electrical standpoint. All right, so let's look at some QEEG profiles briefly. And I do acknowledge that we may want to have more time to review these profiles more comprehensively. But the purpose for now was to introduce kind of some common QEEG profiles relative to substance use disorders as well as mental health disorders. We will also look at some of the neurobiological regions that we discussed on our intro slide through source localization. Okay, let's go to the next slide. Oh, we're on it, perfect. So this is a common profile that we would see in chronic alcohol use, one of the most common drug of choice. So this is what we call a low voltage fast EEG profile, where there's an overall reduction in electrical energy of the brain, represented by that deeper blue coloration, and more so in the slower frequency bands if we see where it says delta theta, okay? So this presentation can be attributed to neurochemical disposition, right, that alcohol creates through the brain, which is an increased demand for a neurotransmitter called GABA, which is responsible for relaxed and calm states. Here we're primarily seeing frontal lobe dysregulation in the delta band. And on the right, we can see our source localization model. You can kind of see a red cross in that image, very visually, might be hard to see, but essentially that structure in white towards the front of the brain, that little picture, the brain is looking towards the left. We see this area being highlighted, which is the anterior cingulate gyres. Again, a key role in controlling ascent of salience and decision-making. And down below, we see the symptomatic presentation of someone with this type of brain activity that can be attributed to chronic alcohol use, such as symptoms of over-arousal, which may present as restless or anxious, compulsive behaviors and thoughts, sleep dysfunction, as well as fine motor difficulties. All right, we go to the next slide. So here's a common profile that we would see with cannabis use disorder. And we see primary frontal lobe dysregulation and overactivity in the alpha frequency band. So if we see that darker orange and red color there, which research has linked to blood flow, right? So excessive cannabis use can impact blood flow in the brain, where we see a change in the alpha frequency band. And again, if we look at our source localization model on the right, we are seeing that this primary subcortical region responsible for this overactivity is that anterior cingulate gyres, right? So again, we're seeing that key player involved with this presentation. And with this profile, with cannabis use, it presents as inhibited, right? So typically for those individuals, the world can kind of just pass these individuals by and they can't keep up. And some of the most notable difficulties or presentations are difficulty with emotional engagement, inattentiveness, reduced affect, and reduced motivation and cognitive control. So opioids are typically associated with excessive slow wave activity. And we can see here in our topographical maps, there is a significant excessive theta profile, right? And so we know that opioids can create an analgesic effects which block excitatory neurotransmitters that are associated with the faster frequency bands of neural excitation, such as glutamate. So again, when we look at our source localization model, we see where is this activity coming from? We see it twofold this time. We see it from the anterior cingulate gyres, and we also see it from the nucleus accumbens, which is that lower structure just below. And this was also highlighted in our intro slide to neurobiology of addiction. So we're seeing these two key players pop up for this particular individual or profile with dysregulation due to opioid use. Okay. Stimulants. All right, so stimulants such as Adderall, we will see typically a faster electrical profile with excessive beta, high beta activity. So stimulants such as Adderall increase norepinephrine, an excitatory neurotransmitter, which we have established is associated with the faster bands of activity. So we see excessive beta, high beta activity here. The source localization model on the right, again, following a theme here, we're seeing the anterior cingulate and the nucleus accumbens as the greatest areas of significance, and we see where is this activity coming from. This presentation is typically associated with hyperarousal states. So if we think, what are the impacts of Adderall? We can see increased emotional and physical states, so greater intensity in those areas. We see excitability and restlessness. We have susceptibility to mood swings and potential sleep dysfunction. So some mental health disorders, and I must preface before, we look at these very briefly, mental health disorders such as depression, anxiety, trauma, they can have many different presentations from a QEEG perspective, but we'll quickly review some of the most common or accepted ones across these disorders, excuse me. So here's a depression profile. A common presentation for depression is this inhibited alpha presentation. So where there's too much alpha activity at the frontal lobes. And this is where QEEG can be exceptionally valuable. And you may have put two or two together and notice, well, hey, this kind of looks similar to cannabis use disorder profile. And you'd be correct in putting that together. And I've seen it so many times working with different individuals, patients who, have a primary diagnosis of depression, ruminations, anxious thoughts, can't calm down the inner thought. And I've tried to use cannabis as an alleviation to calm down the mind, but it ends up making them feel worse. And the fact probably exaggerates the problem. So we could see from a neurobiological standpoint, from looking at the QEEG, if someone had a baseline presentation of too much alpha power due to the impacts of stress or depression, using that drug like cannabis is not going to be a sound choice. So, when individuals learn this information, it becomes very valuable that, they realize that their drug use is not helping them. And putting it back can really help them start to feel a reduction in those prolonged negative feelings. And this is the very principle in that why medication works for some people and not for others, right? So you really must identify the baseline presentation and understand what the brain needs. So an example you can see on the source localization model that we see the anterior cingulate gyres again as a primary area with greatest significance for depression also. So as well as processing salience to incentives and reward that we have associated with drug use or substance use, the anterior cingulate provides salience to also emotional cues like regulating mood, affect, decision-making, worry, and safety. So we'll go to the next slide, anxiety. So we can actually look at the next two slides collectively, but we'll hang out here for a second. So the slide after this is PTSD and insomnia. But anxiety is correlated with excessive beta waves. So it's a stress response with the release of excitatory neurotransmitters, okay, or hyperarousal of the nervous system, creating feelings of excessive fear, worry, temperament control, anxious cognitive processing, and increased vigilance. So in this case, we're actually seeing source localization. This is kind of a behind view of the brain. We've been looking at a side view all this time, but it's indicating that The amygdala, which we've openly discussed, is a key emotional conditional center of the brain with the greatest statistical significance. Okay, a region that plays a significant role in substance use also. And similar to the depression cannabis axis, we can also introduce the notion of how stimulants would not be an effective medication for an individual who may present with inattention and anxiety. So, for example, if this person with a baseline high beta profile was given a stimulant to help with their ADHD, you're only adding fuel to the fire, so to speak. So next slide. So PTSD, insomnia, again, very similar profile, and can be considered a subset of anxiety in its own right. Does promote with a similar profile of excessive beta, high beta activity, okay? And we typically see this more towards the back of the head, so the parietal and occipital lobes, which creates feelings of hyperarousal, of attention and cognitive systems. So you might see people with increased visual and auditory attention awareness, paranoia, hyperattention, hypervigilance, hypersensitivity, or, somaticization. All right, so QEEG in the neurorestorative model then. So, the 4 key areas of why this is so valuable. It supports assessment, really helps verify and correlate with other findings from clinical assessments and measurements. As we've kind of introduced, it supports medication effectiveness. It's becoming more and more used among psychiatry to see whether someone has a resting profile that responds well to certain medications. It shapes treatment delivery goals and expectations, so it can conceptualize what kind of treatment or combination of treatments will be beneficial, as well as what level of care is needed, or if there's a more significant problem, for example, at bay. It can help shape treatment goals, time needed for treatment, and expectations for treatment. And, it provides objective outcomes for programming. So using QEEG as a progression assessment tool can really provide outcomes of treatment and provide validation, which is the most key part in my work, is to see the validation for the client that these things exist and they can serve as a measure for improvement and progress, and that the work that they're putting forward is paying off.
Thank you. So moving into the neuropsychology and clinical psychology component, I'd like to briefly review the integral role that they both play in the treatment of substance use disorders and in the neurorestorative healthcare model. So first, in looking at neuropsychology provides us with critical insights into brain behavior relationships. And by understanding how substance use impacts the brain, we can better comprehend the resultant behaviors and cognitive deficits. This knowledge allows us to tailor interventions that specifically address the neurological damage caused by the substance use, thereby improving treatment outcomes. An interesting part, going back to Ciaran, to what you said about the bell curve as far as neuropsychology is involved, is there is a bell curve to this where we're looking at standardization in scores, standardization in tests. And for example, if we're looking at something in the average range between the 25th and 75th percentile. However, there's also an important component to neuropsychology that involves what's considered the premorbid abilities. So abilities before the onset of decline, before the introduction of substance use to the brain. A good example to say, let's say somebody had an average score, okay, and they were in the 50th percentile. That would be average based on the bell curve. It would be normal. However, so they may say it was average for age, it was average for education. But if someone's premorbid abilities were in the very superior or superior range, and they received an average score in one or more domains, then that average score, while it may be age appropriate, is not normal for them. Because we would expect those scores to be somewhere upwards in the high end of the high average, the superior or very superior range, closer to their premorbid abilities. An average score would be more than a standard deviation of change. So we're looking at two things here. Is it normal based on the bell curve and standardization on that end, but also, is it normal for each individual? You also have, as a part of this, the clinical psychology. Clinical psychology delves deeper into the aspects of personality, mood, emotional symptomatology. Substance use often masks the underlying psychological issues such as depression, anxiety, trauma. Clinical psychology really helps uncover all of these hidden layers, providing a comprehensive understanding of an individual's mental health. And this deeper understanding is crucial to developing effective and personalized treatment plans. So both fields play an essential role in healthcare and substance use treatment. And neuropsychologists and clinical psychologists work together to provide a holistic approach to the treatment. This interdisciplinary collaboration ensures that we are not just treating the symptoms of the substance use, but addressing the root causes and comorbid conditions that could create a barrier to treatment and recovery. The barrier could be neurodegenerative, for example, such as something that is progressive in nature, like a dementia process. It could also be a personality disorder, such as antisocial or borderline or dependent, where these barriers could serve as either a delay or some type of difficulty, something that maybe we can overcome, whereas something that is neurodegenerative in nature, that is going to be a continual dementia process, is not something that we would expect to see clinically significant improvement or change over time. So one of the key contributions of these disciplines is the production of objective and quantifiable data through various assessments and diagnostic tools, such as when we briefly mentioned, like the R-bands, the MCMI, and other neuropsychological tests. Neuropsychologists and clinical psychologists can generate data that guide and enhance treatment outcomes. These objective measures are invaluable in tracking progress, adjusting treatment plans, and ensuring that the interventions are effective. Moreover, the repeatable assessments offered by neuropsychology and clinical psychology are critical in measuring progress over time. So these assessments allow us to monitor changes in cognitive functioning, mood, and behavior, providing a very clear picture of an individual's recovery journey. This continuous monitoring helps us in making data-driven decisions, ensuring that treatment remains responsive to the individual's evolving needs. In short, neuropsychology and clinical psychology are cornerstones in the field of substance use treatment and also vital components of the neurorestorative model. As we've seen, substance use profoundly affects the brain structure and chemistry, altering its normal functioning and disrupting neural pathways, as Ciaran so clearly explained. So let's briefly explore how these changes in the brain translate into tangible effects on cognitive functions through neuropsychological assessment. First, we consider memory. Both short-term and long-term memory can be severely impaired by substances like alcohol, marijuana, benzodiazepines. This impairment can hinder daily functioning and recovery processes as it affects the ability to learn and retain new information. This brings us back to where we spoke about the hippocampus and its role in learning and encoding new information. Attention and concentration are also compromised. Users of cannabis, stimulants such as methamphetamine and cocaine and even opioids find it increasingly difficult to focus, which can then diminish their productivity and social interactions. And then it also plays a role in, are they able to attend to the information that they are learning as a part of their recovery process. The next area, executive functions, encompassing decision-making, problem-solving, impulse control, reasoning. These are notably impaired by various substances. Executive function, you'll see written on the slide, is the CEO. It is the executor of the brain. It does all the higher level functions. So alcohol and stimulants can lead to poor judgment and risky behaviors, while substances like inhalants and depressants often diminish cognitive flexibility, the ability to move from one thing to another simultaneously or control two simultaneous streams of thought, and the capacity to solve problems. This area is also linked to an impaired ability to resist strong urges, such as using again. Processing speed is another critical area, slowed significantly by depressants like alcohol and benzodiazepines. This slowing can affect all areas of a person's life, from performing very simple tasks to simply speaking or interacting with others. A next crucial area is motor coordination. This is kind of involved in everyday tasks, and it's heavily impacted by alcohol and sedatives. The next area, perception and sensory processing. This takes a surreal turn with the use of hallucinogens and dissociative drugs, as it alters the way that users perceive reality, which can not only be disoriented, but also dangerous. Then we move into emotional regulation, which can often be overlooked or misdiagnosed, but it's critical. Substances like alcohol, stimulants, and cannabis disrupt emotional stability, which can lead to mood swings and emotional distress. And then lastly, you see verbal and language abilities. Those areas can decline, especially with chronic alcohol use. This area is notable because it oftentimes affects social and professional interactions. There's also a behavioral component to the changes in language functioning. So imagine with me, if you will, for a moment, the frustration that would come from knowing the words, but only being able to express them at that rate, or slower, or sometimes not at all. Oftentimes, this severe language deficit can present with depression and isolation, along with a level of embarrassment and wanting to just withdraw because there's an awareness that they can no longer speak and interact the way that they used to, which would be their pre-morbid functioning or their pre-morbid abilities. They're no longer at that level. Next slide.
All right, some interventions then on neurotherapy. And so I'm very conscious of time. But Dr. Deckard, you're going to talk about the brain's ability to heal first, right?
Sure. Yeah, I'll introduce the slide and then move from there onto yours. If we're moving through the model, we would now have assessments, results, diagnoses, and treatment plans from medical, psychiatry, individual therapy, physical therapy, spiritual, professional, neuropsychology, clinical psychology, and neuroimaging. And this brings us to the neurotherapy component. As a field, we understand the brain has potential to heal with abstinence and time, and this natural recovery involves neuroplasticity and neurogenesis. So we're going to move through that with the natural, recognizing the natural ability to heal of time and abstinence, and then trying to increase those abilities with neurorestoration by introducing additional therapies that can improve the potential of the brain to recover, with the goal of trying to bring it back to its pre-morbid functioning or baseline.
So neurotherapy then, so this is where we're looking at direct intervention. So off the basis of neuroplasticity, right, we've all probably heard the term that the brain has the capacity to rewire and refire, right? And so we have direct tools where we can do that and measure that. And that's the realm of neurotherapy. So neurotherapy is essentially, I like to call it physical therapy for the brain, right? We're like the physical therapists. Some people call us neurotherapists. It's a nice term, but it's essentially physical therapy for the brain. So this is the application of a therapeutic tool to the brain, CNS or central nervous system, to help manifest change in neural activity, excuse me. So neurotherapy can be direct, okay, i.e. stimulation, or non-direct feedback, okay? And so we'll briefly have a look at some of the main modalities out there. If we just go to the next slide. So the most common one and most familiar to most, if you have heard of the term, would be neurofeedback. And so there are many different forms of neurofeedback. And the premise surrounds a psychological principle of operant conditioning where the brain can self-regulate and change its neural output based off positive and rewarding feedback. So the brain has the capacity to learn and change its output. And usually this feedback, as we see the individual in the picture here, is being reinforced by visual or auditory cues. And so research has shown that neurofeedback can benefit a wide range of clinical conditions as well as peak performance. Electrical stimulation, many different modalities such as direct current, alternating current, electromagnetic frequency therapy, cranial electrical stim. These are all kind of brothers and sisters to each other. So this involves the input of low intensity electrical current to specific regions of the brain that might be unveiled by the QEEG, kind of like a baby version of TMS. So stimulation works by increasing or decreasing neural excitation by input of a selected electrical current. So again, looking at what the brain needs and tailoring a very specific STIM program to give the brain what it needs. So it can really help break up old neural formations. Okay, so it really provides the basis to reorganize brain activity and provide the foundations of neuroplasticity. And STIM has a lot of research showing how it can help multiple clinical conditions as well. We've also got photobiomodulation, which is a direct application of infrared light to selected regions of the brain. It's a form of STIM also, but it's mainly utilizing electromagnetic energy from the light to increase cell energy, which in turn can increase blood flow to regions of the brain. And so a lot of early research, has shown that this is a very effective treatment for injury. So people who may have TBI, as well as older populations who may have neurodegenerative disorders. We also have sound or frequency stimulation. This looks at targeting frequencies through the auditory canal, right? So a listening device primarily targets the vagus nerve. So some of us may have heard of the vagus nerve. I really encourage you to look into the polyvagal theory if you have not yet. Really effective psychological principle from Dr. Stephen Porges, but it reorganizes oscillations in the vagus nerve. So this is a really important cranial nerve that goes from the brain stem through the heart, through the digestive system, and it allows for neuroplasticity and change of autonomic nervous system responses. And then lastly, we have hyperbaric oxygen therapy, what is a little bit more comprehensive, a little bit more cost effective or more cost expensive, should I say. So this involves, high level of oxygen saturation to the tissues, okay? So this is very, very valuable. What research is pointing to regards injury again, so TBI, stroke, neurodegeneration, as well as the healing of substance use damage from toxicity and inflammation.
So in the neurorestorative model, the method of measuring therapeutic outcomes to ensure effective evidence-based care is shifted from the subjective surveys and brief self-report assessments to objective and quantifiable assessments via the avenues discussed in previous slides. So we'd like to take the next just couple minutes to briefly review some examples of outcome data from neuropsychology, clinical psychology, and neuroimaging disciplines. You can go to the next slide. So just briefly, I know for the sake of time, we're looking here at, which is the repeatable battery, where you can give, there's different versions of this. So this can be given over time to track their progression. This was an alcohol case. And as you can see, the orange is the second session. And this is about 15 to 20 days, but it's after 10 sessions of hyperbaric chamber treatment, and it's also after neurofeedback. And so what you can see is that while there's a little bit of variation there in attention, overall the language, visual, spatial, and memory domains and the overall score significantly improved with this treatment modality. And then we can go to the next slide. Now this is a case, the same thing where we're looking at the R bands, but this is 3 different sessions. So the baseline is the blue, And then the orange is after 10 sessions or status post 10 sessions of hyperbaric therapy. And then the green is after 20 sessions of hyperbaric therapy. If we're looking at time, this is approximately 30 to 45 days from baseline to post 20 sessions. In a case of severe fentanyl use with overdose and traumatic brain injury. And what you can see, again, we have some variation here between first, second, and third, but overall, when we compare the baseline to the final session, after 20 sessions of hyperbaric, there is significant, clinically significant improvement across all domains. And then next slide. Just briefly, this is looking at an MCMI-3 for an alcohol use case. And what you can see here is this is somebody who was treated simultaneously with hyperbaric sessions and neurofeedback. They were also in individual and family therapy. They were also being treated by psychiatry. And what you'll see here is with the use of DBT and an eclectic approach to other modalities, there were, I should say, decreases in this case. There were significant decreases in some of the personality factors that didn't quite reach clinical significance, but in the mood factors, when we're looking at some of the anxiety and the depression and the somatization, along with the drug dependence and alcohol dependence, there was a significant decrease in these scores. And Ciaran, you want to move on to your outcomes?
Yep, sorry, I was on mute there, but I realized the time, so I just want to make sure and respect everyone's time. We've gone a little bit over, but these are some objective outcomes, very quick from a QEEG perspective. So the data at the top with the dysregulation is indicating someone at baseline. Prior to treatment, this was a 63-year-old female with long-term alcohol use, symptomology of anxiety, depression, cognitive difficulties. So roughly after about 6-7 weeks of treatment, which included clinical programming, 20 sessions of integrated neurotherapy, so stimulation-based techniques and neurofeedback, as well as hyperbaric oxygen therapy, we can see the differences in the QEEG from the topographical point of view, as well as the source localization, where we were initially seeing a ton of frontal lobe dysregulation. So these are the outcomes that we can see and provide, and this person felt this difference dramatically. So second quick example, if we go to the next slide. Okay, so this is just another objective outcome. 27-year-old male presents with a long history of anxiety, symptoms of PTSD. This individual had a very, very rapid response to therapy. So this is with clinical programming, 10 sessions of integrated neurotherapy, so stim and neurofeedback. And so we can see primarily this overactivity, the temporal lobe, which is coming from the amygdala, quickly moved along. And so we are seeing profound changes in this individual relative to these symptoms.
Thank you so much, Dr. Deckard and Ciaran. I know we're up against it, so we don't have time for questions, but we did get some great ones. We will follow up with you all directly with answers to your questions, along with the slides from the presentation. Keep an eye out for your email for the evaluation from CEGO to receive your credit. And just quickly, housekeeping things I want to add. Dr. Deckard and Ciaran oversee Caron's 10-day neurocognitive assessment program that we launched about a year ago. It's focusing on what we talked about today, treating the brain for those struggling with addiction, anxiety, depression, any cognitive disorders. Using state-of-the-art neuro-integrated evals, we can diagnose and provide targeted treatment plans. Additionally, on our Pennsylvania campus, we just expanded our inpatient services to teens for substance use and co-occurring disorders, ages 16 and 17. The program includes a lot of specialty care for anger, interpersonal conflict, family conflict, things common with that population. Treatment's gender affirming, and it's also gender separate, with a couple of co-eds groups to help the teens build a healthy, age-appropriate relationship. And finally, last big update, Caron has a number of in-network providers, and we've recently added Optum United Healthcare to our list of contracts, which we're very excited about. And if you want to hear about Caron's programs, services, if you have inquiries about an admission, please feel free to, one, visit our website, reach out to your regional resource directors in all of the areas you see here on your screen. We're here for you 24 hours a day, 7 days a week. Thanks again to Dr. Deckard and Ciaran, and thank you all for joining us, and I hope you have a great rest of your day.